As I begin my talk today, I invite you to think about what pregnancy, birthing, parenting, and family means to you. I invite you to think about how your identities, which include but are not limited to race, ethnicity, gender identity, and sexual orientation, and how these impact the way you picture childbirth. Would you want your birthing room to be filled with all of your loved ones, or would you want it to be alone? Would you want it to be loud and celebratory, or quiet and tranquil? Do you want to be supported by a doula who may share a similar identity to you in order to feel safer in the birthing space? Do you have religious or spiritual beliefs that impact how you want care provided? However it is that you picture your ideal birth, whether it is for you or a loved one, cherish it. This is your unique truth that deserves to be honored as you and your loved one bring new life into the world. Unfortunately, our pregnancies and birthing experiences are too often stolen by a system that favors certain people and social identities over others. The discrimination and obstetric violence, meaning physical, sexual, and/or verbal abuse in the medical system, that continues to perpetrate in the United States today, compounded with the particular vulnerability to mood disorders pregnant and birthing people face, threatens the safety of this population. I have come to believe it is not out of a lack of knowing these facts. The continuation of these often silenced truths seem to exist out of an unwillingness to center the pregnant and birthing people themselves. In these 10 minutes we have together, I ask for us to center this community while we question the current state of the health services for pregnant and birthing people in the United States. It is true that over 1 in 10 pregnant and birthing people experience what is known as a perinatal mood disorder in the United States. The perinatal period refers to the time immediately before and after birth, which is a very vulnerable and powerful time for people. Perinatal mood disorders include postpartum depression and anxiety, bipolar II, panic disorder, obsessive compulsive disorder, postpartum stress, post-traumatic stress disorder, and postpartum psychosis. Individuals who experience depression during pregnancy are commonly found to have poor self-care and nutrition. Some go into labor prematurely and/or encounter obstetric challenges. Perinatal mood disorders are considered the number one concern impacting health and well-being of the pregnant person and their child during birth. This is an incredibly important fact to know, but we must also know that racial and ethnic identity directly impact who lives and who dies from pregnancy-related causes. Black and American Indian and Alaskan Native birthing people are almost 4 times more likely to die of pregnancy-related causes than white people. 4 times. Racial disproportionality during the perinatal period, along with the common occurrence of mood disorders, create 2 major obstacles to health and equitable birth outcomes. So I must ask, what are we doing wrong in our maternity health services? Literature suggests that in order to increase overall maternal wellness in the United States, we must understand the impact of culture on mental health care and treatment. Mental health treatment needs to be accessible, culturally relevant, meaning the patient's culture is foundational to their treatment plan, and that patient-centered. There is a consistent lack of provider understanding and how perinatal mood disorders impact diverse communities and an overall lack of competence in serving them with cultural humility. This invites the question of how to move towards a healthcare system that incorporates providers outside of the westernized approach to medicine, which leads me to what I have found in my own research as I explored the integration of holistic birth services in a hospital setting, which included interviewing 18 maternity providers with different backgrounds and disciplines. These providers include doulas, midwives, nurses, OBGYNs, family physicians, behavioral health specialists, and health researchers. When I asked these participants what they thought about integrating holistic health services in a hospital setting, I found 3 consistent themes in their responses: inclusion on interprofessional teams, culturally relevant patient-centered care, and white supremacy. Inclusion on interprofessional teams recognizes the need for interdisciplinary groups to eliminate hierarchical power structures in the hospital setting, inviting an equal distribution of respect among providers. This includes communication and team building skills that honor the individual expertise of the provider, strengthening the team as a whole. This is particularly difficult when mental health treatment and medicine are perceived as separate and held at different levels of importance. Another theme is the need for culturally relevant, patient-centered maternity care. Whether or not participants agreed on the way for care to be administered, it was clear that individuals recognized that cultural and racial ethnic background does impact how care is provided, especially when individuals may have different needs and goals dependent on their identity. Participants discussed the importance of centering the patient and their care and birth plan and respecting their vocalized needs. Participants' responses differed in whether or not they identified how their personal identity or personal bias impacted the way they may have provided care in the past. Offering culturally responsive care is complicated by racial bias in the United States healthcare system, where Black and Brown birthing people are disproportionately dying from pregnancy-related complications. Racial bias is reflective in many participants' response as they describe their observations of obstetric violence and the silencing of patients of color and their cultural birthing traditions and preferences. One participant portrays their observation of labor and delivery nurses, stating how some nurses would be super respectful about folding Mormon patients' spiritual undergarments, yet some hospitals won't let a woman wear a hijab in labor. So what does this mean? Starting with macro level implications, there is an apparent need to break down hierarchical norms on maternity and interdisciplinary teams to increase knowledge of one another's expertise and enhance collaboration. Other implications for micro practice with birthing communities include the emphasis of cultural and spiritual birthing norms when assessing psychosocial need. Many participants spoke about how the information gained from assessments must be shared with all of the patient's maternity providers for a consistent understanding of patient reality. It is also critical to recognize and identify how groups and organizations impact pregnant and birthing people. Lack of access to healthcare, particularly prenatal care, limits the opportunity for pregnant people to discuss potential complications while evaluating other aspects of health. If pregnant and birthing people cannot access healthcare in their own community or access healthcare at all, the implications can be fatal. Many participants also commented on how the isolation many people feel after they deliver and how this impacts emotional health and access to things like a postpartum appointment. Westernization plays a major role in the experience of isolation, where collectivism in childbirth and childrearing is often not the reality. Individuals who are raised outside of an individualistic culture may seek and thrive in a collectivist environment. This needs to be recognized and centered in birthing experiences, even if they differ from provider norms and preferences. Understanding how the macro level, which includes system and structures, impact pregnant and birthing people is vital in making long-term sustainable change. The healthcare system in the United States is grounded in colonization, particularly maternity services. One participant articulated how modern gynecology created the field out of anesthetized surgeries and experimentations on Black slave women. Maternity health providers have to recognize that historical trauma exists in communities of color when engaging in formal healthcare systems, particularly Black and Native individuals. Obstetric violence continues to occur today. For hospitals to integrate culturally responsive, patient-centered services, providers must recognize the impacts of capitalism, racism, and sexism. Widespread communication and massive dissemination of research and evidence-based practices are fundamental in breaking down individual bias and stereotype, and recognizing how personal identities and beliefs may impact the patients we are working with. It remains unclear if the hospital setting can truly integrate holistic services without perpetuating harm to communities who are most at risk of violence and discrimination. In a white supremacist nation, I invite you all to ask yourselves, which voices and lived experiences do I pay attention to? Who do I center when I seek to create meaningful change in my community? As a white maternity provider myself, I ask this question every day. Pregnant and birthing people in the United States face particular vulnerability to mood disorders, discrimination, and obstetric violence. The perinatal period is one of the most powerful and transformational times in a person's life. As a nation, we must do better for this population, as they are responsible for the continuation of community, family, hope, and love. I will end with a quote that speaks to the perception of pregnancy and birth in the United States. I think we kind of still have this cultural understanding that if a woman comes into prenatal care, somehow she's going to magically have a great birth outcome and really be happy being a mom. And that's just not the case for a lot of women. And I think that gets lost in this kind of dreamlike state we have around birth and infants and newborns. So I invite you once again to listen, question, and tell your truth.